Okay, what we're going to do today is have United take over the presentation. While we're going, if you have any questions, you can type them into the chat feature, and we'll use the time at the end to address any of those questions. So please feel free to let us know what's on your mind and what you're wondering about, and I will turn it over to Stacy for the presentation.
Thank you, Carly. This is Stacy Boyce, and I'm a clinical manager with United Healthcare based out of Middle Tennessee. I've had the pleasure of working on HEDIS for about a dozen years now. Most of you are probably familiar with my team of nurses. They're referred to as clinical practice consultants. They're out in the field and meet with you on a quarterly basis to talk about gaps in care and our HEDIS measures. I do want to apologize straight off that you won't be able to hear from our lovely quality director today, Kim C. She is on the phone, but she's got a little bit of an upper respiratory deal going on this afternoon, so you'll just get to hear from me today covering all of this information. But she is here on the phone and will be able to assist with any questions that you guys may have at the end of the presentation. So as Carly mentioned, we wanted to start off today with just a foundational review of what NCQA is, what accreditation is, and what HEDIS is. Where does it all come from? As Carly mentioned, there will be additional webinars later on that will cover more of how these things relate directly to you as a practice, but we thought that it was really important to start off with just a foundational review of the history of all of these things, where they came from, and why they're so important. We're going to start off talking about NCQA. NCQA stands for the National Committee for Quality Assurance. It's been around for a long time. It was founded I can get this out here. Founded back in 1990 and has been central in driving improvement throughout healthcare, helping to elevate the issue of healthcare quality to the top of the national agenda. It's a widely recognized symbol of quality that you'll see down there at the bottom of the page. Organizations that want to use that seal have to first pass a rigorous, comprehensive review that has to be attested to annually for performance. For consumers and employers, this seal really means that an organization is well managed and delivers very high-quality care and service. As of right now, NCQA offers 7 accreditation programs, 5 certification programs, 2 distinction programs, and 6 recognition programs, of which CCMH is one. These programs apply to organizations like MCOs, and individuals ranging all the way from health plans, physician networks, and medical groups all the way down to individual physicians. Health plan accreditations. All of the health plans here in Tennessee are required to carry the NCQA accreditation. All of us have to go through a rigorous set of more than 60 standards that we have to report on for performance, and that covers 40 areas in order to attain that seal of approval. That accreditation is made up of 2 major factors, including standards and performance measures, which include the HEDIS and our member satisfaction CAP surveys. As of this year, that weighting on scoring is a 50-50 split. 50 of the points come from the standards, and then 50 of the points come from a combination of our HEDIS performance and the CAP survey results. At the highest level of performance is an excellent accreditation. The plans have to achieve 90 to 100 points to hit that excellent level. The next level down is commendable, which is 80 to 89.99, and that is where I believe all 3 of our MCOs here in Tennessee are falling right now. Then the next level is accredited, that's 65 to 79.99, and the other 2 are areas that we really don't want to find anyone in. That's provisional and also denied. In addition, we are also rated. So these ratings are based on quality measures that include clinical quality from HEDIS, measures of that consumer satisfaction, which includes the CAP survey, and then the review of the health plan's quality processes. Those are the accreditation standards. NCQA rates health plans that report quality information publicly. The overall rating is the weighted average of the plan's HEDIS and CAP measures plus those accreditation standards. And that rating is based on the performance of dozens of measures and is calculated on a 0 to 5 scale. Performance includes 3 subcategories: consumer satisfaction, prevention and treatment, and the accreditation standards. and the Quality Compass all lines of business, 10th, 33rd, 66th, and 90th percentile are used for those ratings. So a plan that is performing in the top decile of the plans would get a rating of a 5, and a plan that is performing in the bottom 10% of plans would get an overall rating of a 1. We'll talk a little bit about patient-centered medical home. This concept has been around for a very long time. It was first introduced by American Academy of Pediatrics in 1967. In 2008, NCQA launched the first recognition program. It's a model of care that puts patients really at the center of care. And the research has shown that patient-centered medical homes improve quality, patient experience, and staff satisfaction while reducing healthcare costs at the same time. That is the foundation of the triple aim approach. The patient-centered medical home from NCQA is the most widely adopted program in the country. Right now, there are about 12,000 practices representing 60,000 clinicians that are recognized. Each year, your practice has to check in with NCQA to show that their ongoing activities are consistent with that model of care. That annual check-in includes attesting to policies and procedures, and then that process will sustain the ongoing recognition. There are 6 concepts in the recognition program, and we're going to talk a little bit about each one of those. The first concept is team-based care and practice organization. This really just means that the practice is providing continuity of care, that they're communicating the roles and responsibilities of their medical home to the patients, families, and caregivers, and that they're organizing and training staff to work to the top of their ability to provide effective team-based care. The next concept is knowing and managing your patients. This just means the practice uses information about the patients and community that they serve to deliver evidence-based care that supports the population and provides culturally and linguistically appropriate services. The next concept is patient-centered access and continuity. The practice needs to demonstrate here that there's 24/7 access to clinical advice and care, and that this is facilitated by their designated team. And it also considers the needs and preferences of the patient when modeling those standards for access. The next concept is care management and support. The practice needs to be able to show that they are systematically tracking tests, referrals, and care transitions to achieve high-quality care coordination, lower costs, and to improve patient safety to ensure effective communication with the specialists and other providers in the medical neighborhood. The next concept is care coordination and care transition. Again, the practice needs to show that they're able to track tests and coordinate care across specialty, facility-based care, and community organizations. And then lastly, performance management and quality improvement. The practice needs to establish a culture of data-driven performance and improvement on clinical quality, efficiency, and patient experience. Must also show that they engage their staff and patients, families, and caregivers in the quality improvement activities. Recently, PCMH redesigned the recognition program to remove the levels that used to exist, and now they've moved to more of a single recognition status. To receive recognition, each practice has to complete at least 25 elective credits in addition to the 40 core criteria. One thing that I do want to point out here is that the recognition is actually at the individual practice location, site level. It is not the overall PIN level. Now we're going to move on to talking about HEDIS. If you've ever actually wondered what HEDIS means, HEDIS stands for Healthcare Effectiveness Data and Information Set. Also been around for quite a long time. It was developed by NCQA in 1993. 90% of all of the health plans use HEDIS to measure their performance, care, and service. It's a set of very standardized measures that specifies how organizations collect, audit, and report performance across clinical areas as well as customer satisfaction and patient experience. As of right now, there are 94 HEDIS measures that cover 7 domains of care. Those include effectiveness of care, access availability, experience of care, utilization and risk-adjusted utilization, relative resource use, health plan descriptive information, and then measures collected using electronic data systems. The data for HEDIS is collected several different ways. That includes surveys, medical chart reviews, and then claims data. As I mentioned before, HEDIS is one component of the overall accreditation process. The HEDIS measures are updated every year by NCQA to reflect the most current clinical practice guidelines and evidence-based healthcare practices. In addition, HEDIS is open for public comment regarding those new measures and changes every year, and I did include the link down there for those of you who may be interested in that. I won't go through all of these one by one, but I just wanted to point out the different domains of care. The largest domain is the effectiveness of care domain, has 55 measures in there. These are the measures that most of you are familiar with: breast cancer screening, controlling high blood pressure, our diabetes measure. All of those 4 measures are in that domain of care. The next domain is the access and availability of care. Most familiar measure there would probably be the prenatal and postpartum measure. Then we have the experience of care domain, which includes those surveys that we were speaking about. Next is the utilization and risk-adjusted utilization domain. Most commonly known there are the well-child measures. We have the relative resource use domain, which is currently suspended by NCQA. The health plan descriptive domain, which includes things like board certification and language and race information. And then lastly, we have the electronic clinical data systems domain. A few things that are important to point out about HEDIS. HEDIS is a retrospective review, which means that if we're talking about HEDIS 2018, we're actually looking at care that was provided in 2017. Each measure has a specified period that they look at, and that's defined in the technical specs that are released each year. The majority of the measures look at care that were provided just during that measurement year, but there are several measures that have multi-year look-back periods. For instance, colorectal cancer and cervical cancer screening have multiple-year look-back periods. The majority of our HEDIS measures are administrative, which means that those rates are derived just from claims information and any supplemental data that we may have. A smaller subset of those measures are hybrid, which means that we also have to collect physical charts in order to gain that information. So every spring when we come knocking at your doors asking for charts, that's what we're doing. I do want to point out that one of our measures, the controlling high blood pressure measure, is 100% hybrid, which means we cannot get any information from claims. We have to obtain the charts on all of those. In addition, a member can qualify for a HEDIS measure in like a multitude of different ways. That includes their age, any diagnoses that they may have, prescriptions, inpatient discharge, and a lot of other factors. Each one of those measure qualifications are defined in the technical specs as well. Each measure also has a continuous enrollment requirement, which qualifies the member for the denominator, and there are allowable gaps in coverage for each one of those measures as well. As I mentioned before, the measures are updated annually. They add new measures, retire old measures, and update existing measures. Each MCO also collects and submits supplemental data, and one of those commonly known sources would be the State Immunization Registry. I do also want to point out here that supplemental data is subject to annual auditor review and approval, so for that reason, coding is always the gold standard for NCQA. We'll talk a little bit about the Member Satisfaction Survey, referred to as the Consumer Assessment of Healthcare Providers and System, or CAP. They're designed to capture reliable information from consumers about their experiences with healthcare. There are 4 versions that are available for adults and children in both Medicaid and commercial plans. These surveys include a core set of questions, with some questions grouped into composites and some into summary results for key areas of care and service. Health plans that report survey results as part of their HEDIS data collection. So some of the overall ratings include overall rating of the health plan, health care, personal doctor, and specialist. The composites include getting care quickly, getting needed care, customer service, how well doctors communicate, shared decision-making, coordination of care, and health promotion and education. Smoking cessation and flu shots are also covered in those surveys, and answers are recorded as a yes, no, 0 to 10, or always, usually, sometimes, and never responses. In addition, we also have the Medicare Health Outcome Survey, referred to as POS. The goal of this survey is to gather, again, clinically meaningful health status information from the Medicare Advantage program. And we use that information to drive our quality improvement activities, pay for performance, program oversight, public reporting, and obviously to improve the health of our members. All managed care organizations that have Medicare contracts must participate in these surveys. The survey is administered annually to a random sample of beneficiaries each spring, and then 2 years later, that same group of respondents are surveyed again. What does that mean for you as part of the Tennessee PCMH and THL program? In addition to what we've spoken about already, for the Tennessee PCMH program, only members that have a cumulative 9-month attribution to your PCMH will be included in your performance outcomes. Those 9 months do not have to be consecutive, and they are applied at the end of the measurement period. In addition, all of the PCMH and THL practices have access to the CCT tool, which provides those critical care opportunity information and the ADT feeds for tracking inpatient and admission discharge. Each practice is also going to receive quarterly performance reports that represent your performance during a given time frame. The CCT is going to have more current information than the performance report. Each MCO is also going to give you comprehensive care opportunity reporting that will cover that broader set of the 90-plus HEDIS measures that are out there. We have also provided HEDIS coding guides available to you on the tools section of the CCT. These coding guides have been specifically customized to represent the code sets that are appropriate for use in both the primary care setting and the behavioral health care setting. And just a reminder there that care opportunity reports are a tool, but ultimately we're looking for practice transformation when you're looking at the population as a whole and implementing these things on a daily basis. Knowing the requirements of the HEDIS measures will help ensure that those care opportunities are going to be closed for all of your patients. And I believe we have reached the end of the presentation. I'm going to stop sharing and see if we have any questions in the chat box. Do not see any.
Hi, thanks, Stacy. This is Carly. I think this was helpful. Can you talk a little bit about how the HEDIS accreditation for you might be different than the HEDIS accreditation that a PCMH organization is looking for, but how they're both in the NCQA accreditation, but they're both aligned and looking at the same kind of goals?
Right. And Kim is our NCQA accreditation specialist here, so I'm going to try to answer this and have her chime in too if she has any additional commentary on that. But the standards really are going to have quite a bit of overlap with what you're being asked to do as a PCMH and a THL. It's really looking to show that you're really driving quality performance across your organization and providing the best level of care to your members. The standards will be a bit different from an MCO to actual practice level, but the end goal is the same, to really make sure that we're delivering the best quality care and coordinating that care across the continuum with our patients. Kim, do you have anything else to add there?
Stacy, that's very well said. The only thing I was going to add is the fact that one of the other MCOs, Amira Group, will be doing a PCMH-specific overview for the PCMH accreditation certification. So, no, thank you. It's all the main goal of everything is to provide the right care at the right time in the appropriate setting that the member needs. So everything that we do and that you do, we have the same goal in mind. Thank you.
Thanks, Kim. One question, Stacy. What can a practice do if they're really struggling to improve performance on one or two of their HEDIS metrics?
Okay, so that's where the clinical practice consultants on our side, and I believe the other two MCOs have teams that work on this as well, but that's really where the strength of the CPC comes into play. they're looking at your performance every month, and on a quarterly basis, they're meeting with you to identify areas where improvement needs to be made or where you may have some low-hanging fruit, where you're really close to meeting those metrics. In a lot of instances, it's a simple coding tweak for some of these measures that can be made that will show your improvement to really just skyrocket after you've made a few changes. Our team actually will even work with you with your EMR vendor if that's a problem, in making sure that all the codes are flowing through the way they need to, but also just making sure that everyone understands the measure requirements and just working together as a team to maximize that performance. So I encourage you to make use of those CPCs when they're out there meeting with you. They will be working on action plans with you to kind of pick those areas where you have the most opportunity.
Thanks, Stacy. So one question came in asking where they can find the coding reference guides. And I will just answer that and say that when you log into the Care Coordination tool, there's a tab on the left-hand side called the Knowledge Library. If you click the Knowledge Library, all of those coding reference guides are there. And so that's really the best way to access them.
Okay, Carly, I don't see any other questions in the chat box.
Me neither. Well, thanks everyone for joining us on this Friday. Please tell your colleagues if they weren't able to join that we'll be hosting this again next Tuesday, and we'd be happy for them to join then. Thank you.
Thank you, guys.